Good morning to all of you. Welcome back to another session of CME. This time we have Dr. Samara presenting an interesting case. It is about viral encephalitis. So over to you, Dr. Samara.
Good morning, everyone. I'll be speaking today about approach to suspected viral encephalitis in children. My name is Dr. Samara, and I'm a pediatric specialist at American Mission Hospital. The reason for that triggered me to speak about this topic is earlier this month, I had a patient brought by mother, a 14-month-old boy who was brought in by mother with complaints of fever and upper respiratory tract symptoms, coryza, rhinorrhea, that was preceded by a diarrhea for around 5 days. So he had initially 5 days of diarrhea, followed by fever and upper respiratory tract symptoms. The mother brought him to the clinic concerned mainly about the high temperature that is not responding to antipyretics, as well as the poor oral intake and lethargy. He was extremely lethargic. She mentioned a history of a recent travel. They were traveling from Dubai the day before, where initially in Dubai, while they were in Dubai, they presented to another private clinic and they had a pharyngeal swab done, which was positive for enterovirus. So this case prompted early recognition because of the poor oral intake, lethargy, and the child. So initially, with the history taken, we proceeded to physical examination. He was stable, vitally stable. We managed the fever. We gave fluids for dehydration. We gave antipyretics. His labs were reassuring. He had a negative CRP. White blood cell counts was slightly reduced.
Dr. Samara, are you moving the slides? Because we can see only the first one.
Yeah, this is so he was suspected to have, so that prompted me to speak about viral encephalitis. Okay, so we're going to go over some definitions. So encephalitis versus encephalopathy. We want to recognize clinical features of viral encephalitis and understand diagnostic approach, including review of investigations, and then discuss current management and complications of viral encephalitis. So definition, what is encephalitis? Encephalitis is inflammation of the brain parenchyma. And it is either infectious or autoimmune. So it is classified into infectious or autoimmune. Most commonly, it is caused by a viral pathogen. Whereas meningitis, on the other hand, meningitis is inflammation of the meninges. And encephalopathy refers to disruption of the brain function in the absence of direct inflammatory process in the brain parenchyma. So encephalopathy refers to any process that involves metabolic, hypoxia, or drugs that can alter the brain function. Encephalomyelitis, myelitis is infection or inflammation of the spinal cord. So encephalomyelitis involves inflammation of the brain parenchyma as well as the spinal cord. So in overview, encephalitis versus meningitis versus myelitis. So as we mentioned, encephalitis is inflammation of the brain parenchyma, and it is mostly caused by viral pathogens, most commonly, but can be caused by other pathogens such as bacteria, fungi, or parasites. Meningitis is inflammation of the meninges or the brain covering and the spinal cord, while myelitis is inflammation of specifically to the spinal cord. Okay. So epidemiology, the incidence of viral encephalitis ranges from 4 to 10 cases per 100,000 per year. It is highest among toddlers, infants younger than 1 year of age, and viruses is the most common cause of encephalitis. Now, there's some seasonal and geographical variation. Seasonal variation, so it differs. For example, in the late summer to fall, most commonly we can see cases involving enterovirus and arbovirus, while as HSV or herpes simplex virus spreads all year around. Following the introduction of vaccines, there is a decreased number of viral encephalitis worldwide. So geographical variations, you can see in Asia, most commonly we have the Japanese encephalitis, in Africa, the West Nile virus and rabies. In the Middle East, we have the West Nile virus, arboviruses, and HSVs most common. So again, worldwide, we have the herpes viruses, type 1 and 2, varicella, Epstein-Barr, CMV. In Middle East, we have the West Nile virus, rabies as well, but it's very rare, dengue fever, and looping ill virus. So as we mentioned, we have two classifications. We have the infectious or autoimmune. In regards to infectious, we have the viruses that are most commonly identified etiology. Bacteria, fungi, and parasites are less common, and sometimes are unknown causes. Sorry? Yeah, am I clear?
Yeah, please go ahead.
Yeah. So most common viral pathogens, we can see enteroviruses, such as ecovirus, Coxsackie virus, A and B, and the numbered enteroviruses. Those that we know of, the hand-foot-mouth disease. Paraecoviruses, herpes simplex virus type 1 and 2. You can see herpes type 1 is most common in older children, while type 2 is causes neonatal encephalitis. Other herpes viridae, such as Epstein-Barr, varicella, CMV, and human herpes type 6. Influenza viruses, arboviruses, like we mentioned, and less common pathogens, Nipah, rabies, and Japanese encephalitis virus. This is an overview of the types of viruses where we can see the manifestations, brain manifestations exactly. So HSV causes basal, frontal, and temporal lobes, usually evident on MRI, while as type 2 is mostly in neonates. Other viruses, including enterovirus. So the patient that I saw earlier had an enterovirus positive swab on nasopharyngeal swab. So the enteroviruses, they are the family of the non-polio enteroviruses, including the eco, Coxsackie, A and B, and the numbered enteroviruses, as well as the human paraecoviruses. So they account for 10 to 20% of viral encephalitis cases, and they are a single-stranded RNA viruses. Usually common in the temperate climates, and they cause the hand-foot-mouth disease. Herpes simplex viruses, they account for 5% of cases of childhood encephalitis. They are double-stranded DNA viruses. We have two types, HSV1 and HSV2. Like we mentioned, HSV1 is more common in older children, and it can cause, it's the most common confirmed causes of sporadic fatal encephalitis. So it's 2.2, the incidence is 2.2 cases per 1 million population per year. While HSV type 2, herpes simplex type 2, it's one of the common causes of neonatal HSV infection. Other herpes viruses, including Epstein-Barr, CMV, human herpes is more common in the immune-compromised. And then we have varicella. Arboviruses, such as La Crosse encephalitis, which is common in America, especially in north of America, it can cause CNS infections in the ages of 5 to 9 years and during the summer months from July to September. It presents with mild meningoencephalitis and subsequently neurological deterioration. EEG may show focal activity as well. West Nile virus is transmitted by mosquito bites, and it can cause CNS disease in less than 1% of infected persons, and it is rare in children, so it is a disease of adulthood. Influenza virus is one of the recognized causes of viral encephalitis. It can be seen in 5% of cases, and the majority are in infants and children less than 5 years of age. Other non-viral pathogens, including bacteria, mycoplasma pneumonia, is a frequent cause of encephalitis, chlamydia, Borrelia, Lyme disease, and Bartonella, which causes cat scratch disease. We can see also Listeria and Mycobacterium TB. On the other hand, autoimmune classification of encephalitis, which is known as ADEM or autoimmune acute disseminated encephalomyelitis, also known as post-infectious autoimmune encephalitis. The pathology, mainly it is triggered, it's an infection anywhere else in the body that triggers an autoimmune process that involves the CNS and can cause molecular mimicry, and it attacks the CNS myelin. So it causes a spinal cord inflammation. So as you can see here, it affects usually the gray matter, the basal ganglia, and the spinal cord as well. Now, pathophysiology of encephalitis, usually viral invasion causes neuronal damage. It can also be immune-mediated, like we mentioned in ADEM, and causes edema and necrosis of the brain parenchyma. Okay. The main diagnostic criteria for viral encephalitis includes altered mental status that is more than 24 hours, plus two or more of the minor criteria, which is fever, seizures, CSF pleocytosis, and EEG or MRI changes. I think the picture is not very clear, but it just means this is the major criteria. So altered mental status more than 24 hours, and then the minor, any two of the minor criterias. Clinical presentation, viral encephalitis presents, majority of cases, they present with fever. Some causes altered consciousness, headache, seizures, irritability, or some behavioral changes, and focal neurological signs, evident in cranial nerve palsies, abnormal movements, and weakness. Usually children and adolescents, they can present with other signs and symptoms of such as psychiatric symptoms, ataxia, movement disorders, and SIADA. Neonates, however, they can present non-specific symptoms, signs and symptoms such as fever, lethargy, bulging fontanelle is a very significant sign, increasing in head circumference, poor feeding, irritability, and a high-pitched cry. What are the red flags? I can see here rapid deterioration is a red flag, reduced Glasgow Coma scale, focal neurological signs. So if you have unequal or poor reactive pupils, abnormal posturing, status epilepticus is a red flag. Signs of increased intracranial pressure, headache, projectile vomiting, lethargy, irritability. And if you can tell me what this is: bradycardia, hypertension, irregular respirations. These are late signs of the brain herniation.
A small sign. What is it?
Cushing's
Cushing's triad.
Correct.
Cushing's triad.
So it's a late sign. Differential diagnosis of encephalitis can be bacterial meningitis, autoimmune, toxic metabolic causes, and brain tumors. So how do we approach a case of suspected viral encephalitis? Most important, like we all learn in PALS, airway, breathing, circulation. So you check the airway, is it patent or not? You check the breathing, respiratory rate, your SATs, your air entry, if any added sounds. If you have a use of accessory muscles. And then you check your circulation. So your heart rate, blood pressure is very important, and your capillary refill. So you stabilize the patients, you give fluids, you manage the dehydration, you manage seizures, you check glucose, it's very important. So any child with fever plus altered consciousness, do the ABCD, so your airway, breathing, circulation, disability and exposure approach. Then check glucose, control your seizures, assess for raised intracranial pressure. Taking history, what is important in the history? Like we mentioned, travel history, because of the geographical distribution. Travel history is very important. Vaccination status of the child. Was he vaccinated? Did he take the mumps, the MMR, varicella? Now, like we mentioned in the West Nile virus, we have the mosquito bite. So always ask about animal or insect exposure and his immune compromised status. So is he a patient of post-transplant? Is he on chemotherapy, prolonged steroids? Your physical examination includes, most important, is your neurological exam. So check his mental status, assess motor, sensory, reflexes, cranial nerves, Glasgow Coma scale, fundoscopy examination, and check for signs of meningism, any knuckle rigidity. Skin manifestations include rashes. For example, you'll have vesicular rashes in neonates with HSV. You have maculopapular rashes and West Nile virus, and the hand-foot vesicular rashes, which are evident in the palate and around the mouth, hands and feet, and patients with enteroviral infections. Focal deficits, so your pupillary reactivity. And so when do you suspect a viral encephalitis? Any child with fever, encephalopathy, like we mentioned, markers for or signs and symptoms reflecting a brain inflammation. So altered consciousness, lethargy, irritability with the fever. So you suspect viral encephalitis. Any seizure without any clear cause, and behavioral or cognitive changes. Moving forward to initial investigation. So your primary assessment, your basic lab, CBC, including differential and platelets, your CRP, serum electrolytes, blood culture, glucose, very important, coagulation studies, and your liver function tests. And then specifically, you do your MRI. So the MRI is the preferred mode of imaging in such cases. Then CT scan if MRI is not available. And specifically in HSV encephalitis, you check for temporal lobe involvement in MRI. Then lumbar puncture, it is essential unless contraindicated, and we'll be speaking about contraindications later. You measure the opening pressure, you do a CSF analysis. So your CSF analysis in viral encephalitis, like we mentioned, is normal glucose. Sometimes it can be low glucose, increased protein, and lymphocytic pleocytosis. So you have predominant lymphocytes. You will also send CSF PCR, especially HSV, mandatory, enterovirus, and you can also repeat if negative, but suspicion is high. So the main features of viral encephalitis on a CSF analysis, you will have increased white blood cell count, predominantly lymphocytes. Protein is increased and glucose normal or low, or it can be low. Other investigations include viral serology, EEG, and autoimmune panel. EEG, you detect if there's any seizures, and it can show encephalopathy. So signs of encephalopathy on EEG would be diffuse slowing. We call it global cerebral dysfunction. Specific patterns in HSV, you will see periodic lateralization epileptiform discharges, so we call them PLEDs, in the temporal lobe. In arbovirus or Japanese encephalitis, you'll see diffuse slowing with focal abnormalities. And enterovirus, you will have occasional epileptiform discharges or diffuse slowing. Normal EEG does not exclude encephalitis. Okay, so if you have a normal EEG, a normal CSF, it does not exclude encephalitis. The mainstay is the MRI changes. So this is the PLEDs. You can see here the PLEDs, which are sharp waveforms, discharges with lateralization on the EEG, which is more evident in HSV encephalitis. Okay. So in summary, we stabilize the patient. So the approach, you stabilize the patient, you do an MRI, lumbar puncture if it's not contraindicated. You do a CSF analysis plus PCR, and then your targeted viral testing. Then you start in your empiric treatment. So it's very important that you start IV acyclovir immediately in the emergency. The dose is 10 milligram per kg every 8 hours, given over 1 hour infusion for 14 to 21 days. Antibiotics, if you're suspecting bacterial meningitis, and steroids as an adjunctive therapy, either methylpred or dexamethasone. So the dose is 30 milligram per kg daily. Supportive therapy, of course, you need to control the seizures if there's seizures, electrolytes and fluid balance, manage increased cranial pressure, ICU admission. So any cases of suspected encephalitis, your initial approach in the emergency, IV access, send your bloods, start IV acyclovir immediately, plus or minus antibiotics if you're suspecting meningitis. Do your MRI before your LP, and then LP CSF analysis. When do you delay lumbar puncture? When is it contraindicated? If you have a Glasgow Coma scale less than 8, if you have signs of raised intracranial pressure, such as papilloedema, focal neurological deficits, so pupils non-reactive or unequal, so papilloedema, abnormal pupils, and in cases of hemodynamic instability. So you do your MRI first, and then you would consider lumbar puncture. Special situations, as we mentioned in neonates, considering that HSV type 2 is more common in neonates. So the dose is IV acyclovir is 20 milligram per kg, given 8 hourly. Immunocompromised, keeping in mind immunocompromised children, most common pathogens, CMV, Epstein-Barr virus, and varicella especially. Don't forget toxoplasmosis and travel-related infections according to the geographical distribution. Complications of viral encephalitis includes cognitive impairment, epilepsy, motor deficits, and death. Prognosis depends on the pathogen, so etiology, HSV being the most common, predisposes to 75% of mortality and encephalitis. It depends also time to treatment. That's why it's very important to diagnose or have a suspicion early, and also depends on the severity of the infection. So key guidelines, MRI plus CSF PCR, starts early acyclovir, and then tailor testing based on the risk factors. The take-home message, conclusion, always suspect viral encephalitis in a child with fever plus altered mental status. Start your acyclovir early, perform MRI first, and then lumbar puncture. And then, of course, don't forget your multidisciplinary approach. So you have ICU involvement, your neurology. And I'll leave you with this take-home quote. Life affords no greater responsibility, no greater privilege than the raising of the next generation. Thank you very much. I'm open to any questions. This is my new contact number. I think you have my old number, so this is my new number and my email.
Thank you very much, Dr. Samara, for that clear presentation of the case that you encountered. And it would be good. This was the case that you had encountered, right? Can you also let us know what happened to it? What was...
The reason why I didn't add in about the case is because he was shifted to a tertiary center, and it was quite difficult to get any lab reports or any brain imaging reports after that. But it was reported from the mother. I was informed by the mother that he was confirmed enteroviral encephalitis by PCR testing. The child was admitted in Salmania Hospital. Stayed in for 3 to 4 days, and he was discharged. He was doing very well after that. So I'm not sure about because viral encephalitis would have, later manifestations. So according to the mother, he was started on early acyclovir and antibiotics as well, and steroids, and he was doing well. Within 3 to 4 days, he was discharged home.
Dr. Samara,
he didn't have any complications after.
Sorry.
You can stop the Zoom set. Yeah. Go ahead, Dr. Mariam.
Dr. Samara, thank you for the presentation. Yeah, this symptoms, what you mentioned, how did you think actually about encephalitis? Because these things all these presentations can come for any of the cases we see. What was the thing that has made you to suspect and go for this test?
Sixth sense. No, we see upper respiratory tract infections on daily basis. This child was different. He was extremely lethargic. He was drowsy. He otherwise vitally stable. His blood pressure, his heart rates were normal. His pupils were equal and reactive, but he was not himself. So I had this instinct, there's something going on. You keep in mind also meningitis in the back picture, but he didn't have any knuckle rigidity. He didn't have his anterior fontanelle was closed, obviously, so he didn't have any other features apart from lethargy, In between, he was irritable. So he was sleeping the whole time. He wakes up irritable and then goes back to sleep. I observed him in the PTU for about 3 to 4 hours. We thought it might be dehydration. We gave him fluids. We thought it might be the fever. We gave him antipyretics, but he remained lethargic despite all the procedures that were happening. The key home message here, the learning point is, if you have a suspicion, start IV cyclovir. It's very important. I was criticized when I transferred the patient to Salmania that, why didn't you start antibiotics? Why didn't you start IV cyclovir? But without confirming the diagnosis, limitations of the imaging, so we couldn't start earlier treatment.
Yeah.
Flow was okay. Reflow sugar, you didn't mention about the reflow.
Yeah, his sugar was normal.
Yeah.
His
Anyway,
sugar
good.
labs were all normal.
You could diagnose early.
Yeah, thank you for
He
bringing
had
up.
he had an initial diarrhea for 5 days. So you would think of, acute viral enteritis, he's dehydrated, but all of this was managed. We gave a bolus. I gave him 2 boluses as well. And his blood sugar was normal from the start. His bicarb was only 19. His electrolytes were within normal.
Yeah, so he already came with a diagnosis of enterovirus infection because he had a PCR proven diagnosis. So with this clinical
Esophageal swab.
from
And he
from-
had vesicles on his throat. He had some rashes on his hands and feet as well.
so it was much like the hand, foot, and mouth disease.
Yes.
Plus, this is a rare complication, and I think it's a high index of suspicion that will help pick up. Even from here, we had a couple of cases of RSV bronchiolitis that had to be shifted out to Salmania because they were typically lethargic and unarousable in the sense you would expect once the child is given supportive care to be up and about and look well. That is why in pediatrics that appearance is such an important thing. So I think a good clinical examination, good clinical history, and examination findings will help pick up these cases. I'd like to share an interesting case of viral encephalitis that I encountered a couple of years ago while I was in Royal Bahrain Hospital. This was a 9 or 10-year-old boy who came in. He had actually gone to AMH SAR with history of the mother noticed that at the dining table, he just slopped down. He just swooned and he kind of buckled up onto himself. And then they said, "What is wrong with you?" And then he came up around, completed his meal. He developed a bit of a sore throat, some fever. He was taken to the SAR AMH. And then it was discovered that he had tonsillitis. He was, I think, put on, I can't remember if he was started on antibiotics, but then he went home. He had another episode of the swooning. So the mother then rushed it back to the hospital, but was told to see a neurologist, thinking that it was seizure, some seizure disorder, so that they needed to see a pediatric neurologist. So when they came to RBH, the first thing that struck me, I mean, I was seeing this patient earlier from when he was a toddler, that he had pretty altered behavior. He was not recognizing his own parents. And his behavior was bizarre. So any strange behavior of a child should raise alarm that there's something going up in the upper story. So either encephalopathy or encephalitis. So anyway, we did, the long story short, we did the MRI, we followed the protocol, we started him on IV acyclovir. But what happened during the course was he developed lymph nodes. So that prompted me with the history of, and the PCR came out negative. There was no viral etiology. But his combination of tonsillitis and lymph nodes prompted me to get an infectious mononucleosis screen done. And it turned out to be positive. So he was actually an EBV virus encephalitis, which is quite rare. But then as soon as we got this
Right, right.
etiological diagnosis, we stopped the acyclovir. We stopped all the other antibiotics that were started empirically. And it took him some time to recover. It took a couple of weeks for him to inch back to normal. He's actually a very smart, intelligent boy. He had some behavioral issues initially. He was quite, he was put on anti-epileptics for about a year, and then it was tapered off. But right now, several years down, about 2-3 years now since this episode, he is completely fine. He's back to normal without any sequelae. So these are, although the common viruses are what were mentioned today, we will have to keep the whole clinical picture in mind and think of other viruses that can also be a cause. And yeah, this was a big learning that EBV virus can also cause encephalitis. Basically, every virus can cause, theoretically, but having a high index of suspicion and doing whatever tests that are possible will help find out the root cause. Thank you.
I think some cases were mentioned in Bahrain of influenza encephalitis as well.
Yeah, influenza is common, especially neonates, newborns. So where the MRI becomes a modality of imaging.
Samara, the dose of methylprednisolone you mentioned 30 milligram per kg.
Per day.
30.
It's per day, Dr. Preeta.
30 milligram per kg per day.
Per day. Dr. Samara is frozen. I'm not sure whether her internet is fine there. Yeah. You give a high dose of methylpred.
Methylpred, yeah, a high dose.
Okay. Okay.
Any other questions? Any comments? And like encephalitis is important to pick up, even ADEM is important. Again, a high index of suspicion and awareness of this condition. So any child presenting with encephalitis-like picture, where you're not able to fit in the features, especially also when they present with focal neurological signs. I mean, I had a child who presented only with headache, severe headache. And this child was being treated conservatively, but then he developed, he started throwing up. He developed signs of raised intracranial pressure. When he was shifted to Salmania, and their diagnosis of ADEM was done. So there's a question, when is methylprednisolone started? You can read the chat, Dr. Samara.
Yes, when is methylprednisolone administered ASAP, or does hemodynamics need to be considered as well? So methylpred is adjunctive therapy, so you can add it along with the antibiotic and acyclovir, but acyclovir comes first.
Especially when there are signs of raised ICP. I think you'll start.
I think methylprednisolone is not indicated for all viral encephalitis. I think some specific indication, and also you had to do first CSF study Then you have to see, you have to rule out some other autoimmune, anything is suspicion, then only you give methylpred, I think, this high dose. Or it may mask some other autoimmune. But I think unless there's some steroids indicator only for the like raised ICP or something like that, they do but that indication. But methylpred, high dose methylpred, not a initial treatment, as I know.
But it would be the initial treatment, especially if there is coning and raised ICP. That could be life-saving. I agree that or it might mask detection of other autoimmune conditions.
Not the high dose, I think, doctor. Not the, but we have the indication steroid we can use, but anti-edema measures, steroid
But
and other diuretics.
But it is high dose for autoimmune. Even for ADEM, we use a high dose methylpred.
Yeah, that's what I'm saying. You had to do CSF study. Do after that, you collect. Then you have suspicion of any autoimmune or specific thing. Then only you go for the steroid. The high dose. We can maybe use Dexa or something for the anti-edema. You feel like that, but high dose steroid methylpred, if you give before CSF study, you may mask some of the findings like autoimmune lab findings. It may alter.
But I'm just looking up literature. It says high dose, early initiation of high dose methylpred can be life-saving, especially with respect to autoimmune. Early high-dose methylpred therapy is associated with better outcomes in children with acute necrotizing encephalopathy. Also in autoimmune, in certain viral conditions, yes, it can help in spreading the disease, especially in enterovirus. But then in most autoimmune conditions, as we know, that is the treatment of choice also, right? To decrease the
But you have
inflammation.
to confirm it. No, clinically we cannot make this diagnosis. You have to do, it's not the earliest treatment, but you have to do CSF study. Then
Yeah,
you have a suspicion of
understand.
thing.
Correct. So the first
Not-
step, that's what the protocol is, to do an
Yeah.
MRI first to find out if there's raised ICP. There's no contraindication for LP. We do a CSF analysis. Once you collect the CSF, and then sometimes it takes time for the CSF results to show up, unless you have a center where the PCR can be processed quickly. But if there is any suspicion of coning, like this child that I had, the one that presented as ADEM, he was sent home, came back with raised ICT, and he was given a dose of steroids before being sent to Salmania because he was already coning at that point.
But still osmotic diuretics like mannitol or hypertonic saline that may be first helpful. Plus Dexa maybe can be also given.
But based on what we learned in the recent pediatric emergency conference, the dependence on mannitol is, I think, coming down with respect to managing raised in ICP. They're depending more on 3% hypertonic saline. No doubt, in case all that is not available, then go ahead with mannitol. But then steroids have their role. I think we don't have our expert, Dr. Vanita, up there to give the final word. But from what I learned, it is one of the early supportive therapies. Any other comments? Any other questions? The role of steroids is we even use steroids for severe community acquired pneumonia, especially when they have pleural effusion. This will improve, and we give a short dose, short course, 2 to 3 days. So similarly, I think with respect to encephalitis and encephalopathy, the role of steroids is there. But of course, whether to continue or not, whether to continue high dose, all that will matter upon the etiology. Yeah. All right. So if there are no more questions, we will close the meeting. And thank you again, Dr. Samara, for bringing up this important, rare but important case and throwing light on this. Take care. We'll continue the discussion in the pediatric group as to the role of steroids so that we have more clarity on that. Yeah, so all of you have a good day. Bye.
Thank you. Bye-bye.
Bye. Dr. Arun, I just see that you have a few comments in the chat section. We will come back to you on that outside of this meeting. Thank you.